Thank you, Ms. Iacino. Let's go to member questions. Mr. Mathis had a question.
All right. To you first. When you're talking about the appeals in the 60 days and having to complete them, what is the mechanism, if any, you suggest? Let me go back. You talked about appeals being completed within 60 days.
Right, Mr. Mathis. My testimony might have been confusing because there are two different appeals process. One for a facility, a complaint investigated at a facility, and that appeal can be filed with the department, the deputy director of the licensing division. They are responsible. The department is responsible for reaching a decision within 60 days with respect to that appeal, and then notifying the facility once they make that determination whether they uphold the appeal or deny it, notify the facility within 30 days. With respect to a certified individual, a certified nurse assistant, for example, if I've been accused of a situation and I choose to appeal it, that is where Healthcare Services actually adjudicates that particular claim. It's a similar time frame. They need to make a determination within 60 days and then notify me as the individual of the determination. So there's a 60-day window and a 30-day window.
Okay, because you, in here on your comments, you put established timeframes for completing facility-related complaint investigations and develop formula policies for timely processing and complaints against individuals. What would be a time frame you would recommend? Would that be another 60-day time frame?
Oh, you must be referring to, and Tammy might be able to help me, the recommendation with respect to completing an actual investigation of a complaint, where we're suggesting, in the past, the department did have a time frame. They had a 45-day window, 40 days to investigate the complaint, and then actually 5 days to complete it and share the information.
That sounds reasonable.
They eliminated that back in 2009 because they were having difficulty achieving that particular metric. In fact, our 2007 audit report looked at that and analyzed that and said they were not meeting that. We think that time frame, at most, we believe, in discussions with, we don't specify in the report, but based on what we have seen, we think probably a 60-day window would make sense as far as investigating a complaint.
So in 2009, it was completely thrown out, the time frame? See how complete?
And again, the department can answer as to their rationale, but it was my understanding, yes, in 2009, they eliminated that complaint, that time frame, the 45-day time frame. So we didn't have anything to measure against with respect to that when we conducted the audit we issued this past October.
All right, thank you. Sir, you said a need for an automated system. What are you looking at? What are you thinking? What is the mechanism you're looking at drawing with that? I mean, you're talking about a computer system where it updates and it says, okay, this is time to follow up with this patient and this, and getting with modern times, because there's so many software applications that do that already. And it baffles me that as a government agency, that's not already being done.
Yeah, the department's challenged in that it has certain federal software systems it needs to use to track its survey and other related activities. But there are means to extract data from that as well as its other systems to try to unify it. So that's the first is to create a single source of truth for all the data.
So you need a software patch.
One might call it a data warehouse. So you might want to warehouse all that data in one spot so you can have a single source of truth from which you can report on a variety of metrics that the department has in terms of objectives. But the second set of standardization is around the actual workflow or the work process that the surveyor might do or a complaint investigator might undertake. Ms. Iacino talked about having tablets, and on those tablets might be an interface in which a survey or a complaint investigator.
A tablet would be great, but if you're not doing the file share within the server and you don't have the data patch that allows for that, then it's pointless.
Not being the expert on implementation of such technologies, I can imagine that a tablet could later be downloaded when close to a Wi-Fi spot or in the intranet to download the data from the form that was collected during the site visit or investigation.
If it's on a tablet, it can instantly update with the click of a button. And if the network's set up correctly, it'll just automatically share across. And if you have the software patch, which is done correctly, then it'll automatically have the updates and the times to go back and look, so that way your workers have the ability to pull it up, and it'll send them a reminder, hey, today you're doing this claim.
Yeah, and I think that's one of the key points of the automation is providing an aid to the surveyor or investigator about the proper path and steps to follow when
So
you
do you have any
survey.
estimate on when you guys are looking at implementing that, or a path to get there? And that's probably
Yes.
better suited for you.
Certainly. So we, in improving our IT systems was one of the 21 Hubbard recommendations, and so we are working to implement all of them. We, as Mr. Joy mentioned, one of our primary databases is the Aspen system, which is federal proprietary, and so additional steps that we take have to work with the Aspen system, cannot alter the Aspen system. So we are looking at this issue. The fix will not be quick. The tablets, one of the things that we hope to gain from being able to use the tablets is that the federal government does have plans for automating some portions of their system, and if we have tablets, that will work well. Part of it, the most recent thing that will be coming online for us here in California is also helping on the facility side, will allow facilities to automatically, electronically submit their plan of correction. So that's an improvement in timeline with automation, and it also will address one of the auditor's recommendations about following up on plans of correction. There is also, but so we are working on.
But there's not
IT
a timeline
fixes.
yet on when that'll be.
We do not have a timeline on when particular IT fixes will be in place.
Okay, and then you also talked about training and licensing and all of that. What is your ongoing training policy with that? Because I haven't heard anything mentioned about ongoing training versus training for licensing.
So we have a significant training period for new nurse surveyors.
Yeah, I understand. I'm very familiar with the training
Okay.
program. I have friends and family that are work in such facilities. I'm talking about the ongoing training portion for not just them, but also for your own staff.
So we have a number of training initiatives going on. We have sent nearly all, and will continue to send all of our leadership at the branch chief level and above to leadership training. We have there is ongoing training for nurse surveyors as new federal standards come out and new facility types come online. We have training. We're working on a training and onboarding consistent for all new staff who come on that are not nurse surveyors, just training in our processes.
So you have training at the top and training at the bottom, but no training in the middle?
No, we're working on training at all levels within the organization.
Okay.
Thank you.
That's all.
Assemblymember Gibson.
Thank you very much. This is for the Department of Public Health. Regarding staffing levels, can you talk briefly about the measures or the plans that you're putting in place to address some of the staffing levels? Because as I'm reading and hearing, the staffing levels are in fact an issue to address some of the growing complaints that exist.
Yes. So one of the primary steps we're taking to address that is our budget change proposal to request 237 additional staff. And we are also looking at our district offices and a district staffing model to assess workload by district office. This is one of the recommendations of the Bureau's report, so that we can assign those staff by district office to better suit the workload.
What is the staff ratio to patient presently?
So, so statute requires that skilled nursing facilities provide 3.2 hours of nursing per patient per day. That's a facility requirement. We don't have a ratio am I getting at your question?
You are, to some extent. I'm just concerned with not enough staff to handle some of the concerns that I'm looking at to address patient care. Right. And I'm looking at a report that deals with, that can suggest the lack of supervision as well as a lack of individual staff to handle, to address some of the patients, especially with some who have passed away, some that, in fact, dealing with blood clogs and things of that nature, monitoring patients. All that is a concern of mine, and we're talking about in the governor's budget giving the department additional resources. And I don't know if we're throwing good money at bad money, and are we actually addressing some very serious needs when it comes down to patient care? These are individuals that need your facility, that need those skilled nurses to provide a service, and taxpayers certainly demand that the money is used in a very appropriate way to preserve life and to address a need that those patients need. And I'm concerned with the fact that, one, there's a number of open cases that's still yet to be addressed. I'm concerned with the amount of time that your department is taking to address those concerns. I'm concerned that at one time there was something placed or implemented where it took 45 days to implement plus 5 days to report back, and that still wasn't sufficient. Now we're talking about 60 days implementing something for an investigation to report back. I'm concerned in terms of people not doing what they're supposed to do, and then there's no discipline and or follow-up. I'm concerned with what appears to me to be some fines that have been given to facilities for the lack thereof. I'm concerned with a number of reports that the state auditor has given that still suggests patient care is at risk. And I'm concerned that you had a department director that I guess left shortly ago that may suggest also that there was someone sleeping at the switch. That's why you're here. And that person, there's a new person that's being placed in who just came on board a few days ago. So I'm suggesting there's a whole bunch of problems that's going on with this department that to suggest that patients' lives are being placed in jeopardy.
And I recognize all of your concerns, and we share your concerns. The safety of the residents in long-term care facilities is our number one priority. We recognize that we need to do better at our work to ensure their safety.
That's all for right now.
Let me come back to you, Mr. Mathis. We have two other members over here that want to get in.
I've got to follow up on what
Wood.
Mike just said.
Can you hold on to the thought? We'll come back to you. Assemblymember Wood.
Yes, thank you. Just a couple of questions and to follow up to Assemblymember Mathis. You talked about in 2009 that the time frames for investigations were just kind of thrown out. Is that accurate, or did I miss something there?
So in 2009, our internal policies and procedures had a guideline of 45 days.
Okay.
That guideline is no longer in our policies and procedures. I can't speak to I was not present when it was removed.
I guess it'd be nice if you can't meet guidelines just to throw them out. I guess it seems a little. So there are no guidelines then. Currently,
no.
There are no guidelines for
time frames. There is no guideline at this
point. And so and according to the document I have here, CDPH disagrees with establishing guidelines.
So we are using our metrics that we've been posting for 2 quarters now to measure and learn with the public and for ourselves what the timelines, how long it is taking us to perform these activities now. In addition, as I've mentioned, we have a request for a significant increase in staffing. As we get those staff on board and continue to measure our timelines to complete, then we will have a better understanding of what it takes to complete these investigations.
I guess it just seems a little backwards to me. I guess I would hope that you would establish some guidelines and then aspire to get to those guidelines and then revert back to that, rather than go through the motions of doing the work and figuring out how long it takes and then establishing the guidelines based on that. to me doesn't. I'm sorry. There's a bit of a disconnect, and maybe it's me. But I think if you had reasonable guidelines and could aspire to do them, and then found you weren't able to do it for whatever reason, that would be I would think that would be a better approach. I want to go back to the immediate jeopardy issue. Immediate jeopardy means that these are things that should be reported within 24 hours or dealt with within 24 hours. Is that correct?
An immediate jeopardy situation is one that either has caused or has the potential to cause harm to a patient.
So there is a time frame,
right,
for that.
To initiate that complaint. We're supposed to initiate on site within 24 hours.
So, and that's happening now.
96% of the time.
Oh, I'm sorry. I thought it was within 96 hours. I'm sorry. I misunderstood.
No. 96% of the time we are meeting the 24-hour
on new cases.
Yes.
On new cases.
Well, yes, but yes.
So what's happened
every case that's initiated?
So what's happened to the other immediate jeopardy cases, like the 368 that were still hanging out there? Have those been dealt with?
So, as I mentioned, when we arrive at the facility, if we find immediate jeopardy that time, we do not leave that facility until the facility makes a plan to immediately address the situation. The complaint, though, the complaint investigation itself may not be closed out for some period of time after that because there are ongoing things to finish up the investigation.
So those 368 cases that were referenced earlier, those are still out there. There could be the quote unquote immediate danger is now gone, but they're still being investigated. Is that fair?
We do not leave the facility until we are assured that the immediate danger has been abated. I'm not sure the 368 cases to which you refer.
I guess maybe that would be a question for Ms. Howell, because I think that was your number.
Yes, Mr. Wood. That's as of April of 2014, we show a table in the report and we break it out by district office. Identifies the 368 cases. 100 of them were in Santa Rosa, Redwood Coast, one of the district offices. But those 368 cases were open for an average of 340 days. As Ms. Iacino indicated, immediate jeopardy, the initiation is within 24 hours. But as we recommended in the report, and we don't see, there is no specific time frame for when we complete that particular investigation.
Which goes back to my earlier question. Exactly. So I'm curious, you've talked about a lot of monitoring and things. What are you learning about these complaints? What are you learning about prevention and education so that we don't have these complaints? I mean, right now, I believe we still have well over 10,000 open complaints. So what are we learning from this so that we could, rather than having to deal with the complaints, we could be dealing with the issues that are leading to the complaints?
So one of the things that addresses this issue of sort of quality of care ongoing is that the Centers for Medicaid and Medicare Services contracts with Quality Improvement Organization, two of them actually, HSAG and Levanta, and their role is to work with facilities on particular issues that have been identified with our federal partners as areas that need general attention across facilities. So the use of antipsychotic medications, the rate of pressure ulcers, and a couple of other items. And so those quality improvement organizations work with all of the facilities and work with us. We can refer a facility to the quality improvement organization if we see an ongoing sort of issue where we think they need training and help to improve. A facility can seek out on its own the assistance of the Quality Improvement Organization, and then the Quality Improvement Organization undertakes just general activities to try and raise quality. Our department has participated and is participating in an antipsychotic collaborative where we're looking specifically at that usage and how we decrease the usage of antipsychotic medications in facilities.
So how are we doing?
On the antipsychotics, we have reduced the rate. I don't have the statistics right in front of me. The rate is reducing, and there's more work to be done there.
And same with the other quality issues, bed sores, those kinds of things. They are improving.
Yes.
Okay. All right. Thank you.
Assemblymember Rodriguez.
Yeah, just kind of elaborate a little bit more on one of my colleagues, Assemblymember Gibson's remarks regarding nurse per patient staffing ratios. I know you said it was 3.2 hours. That like a national average. Why isn't there like it's 4 patients per nurse or whatnot? Why is it different?
Okay, so there are two different standards. There's one for nursing homes, which is 3.2 nursing hours per patient day, so it's not an actual ratio. And then there are separate nurse-to-patient ratios for hospitals.
Correct.
So in the nursing homes, in addition to that standard of 3.2 nursing hours per patient day, facilities are required to staff adequate to meet the needs of their patient. So if we're in a facility on a complaint investigation or a recertification survey or whatever we're in the facility for, if we determine that they are not staffed adequately to meet the needs of their current patients, we can cite them for a deficiency for that. In addition, on a separate track, we have staff that go to and specifically audit for skilled nursing facility compliance with the 3.2. And those auditors, they are working in conjunction with the Department of Healthcare Services and their quality program. And so we are in 100% of the skilled nursing facilities specifically auditing for the meeting of that staffing standard. The percentage of compliance on those audits is in the 90% range.
Now, on complaints, is there certain complaints that take longer to investigate than others? And if so, can you give me examples?
Yes. So definitely some complaints take longer to investigate than others. Some complicating factors could be if the patient or the person, a facility staff member was involved, have left the facility. That could take longer to track them down. It can sometimes be more difficult to investigate a complaint if the resident that's involved, because of dementia or some other issue, is not able to communicate or remember or provide a reliable account of the alleged incident. Those would be some examples.
And just one last question on licensings of individuals, whether they're CNAs, nurses, or whatnot. When you're doing the investigation, do you check to make sure those licenses are current and those licenses are from a institution that is credible for licensing?
Yes, we certify the certified nurse assistants, which are the primary staffing in most skilled nursing facilities. And so they have to complete a curriculum that is approved by us, pass a criminal background check, and then we certify them. And their certification is good for a period of time, at which time it expires. And then the facilities are also very careful to ensure that the staff that they hire have up-to-date certification. And then if we have an investigation against a certified individual, then we can take actions to suspend or revoke that person's certification, send them to a diversion program and other activities.
Okay, thank you.
Thank you.
Mr. Mathis.
Thank you. Back to you. With this caseload, so you have zero. There's no equation on the caseload that you guys are handling, like per capita. Like you said it, that you guys don't have a number on how many cases per your staff that they need to be working, and your solution is to hire more staff. Now, throwing more staff at a problem isn't going to increase the timeliness of it getting done. If there's not a specific time frame laid into place, there is no goal, and throwing more people at it. I mean, I could have 100 guys saying, hey, do this, but don't worry about when to get it done. And they're going to wait till the last minute to get it done. But if they don't know what the last minute is, it's not going to get done. You understand what I'm saying?
I do understand what you're saying, and I would say a couple of things. So we measure workload. You had asked some questions earlier about the estimate and how we measure workload, and we determine a level of staffing needed based on a 3-year average of the number of hours it takes to do each type of thing. So that's how we assess the number of staffing we need. And then we're using our performance metrics that show how long it's taking us and breaking those out by district office to identify where we have people, where we have offices where staff are not completing.
I know. My point is that you're giving estimates on how long it takes for people to get something done when they have no time frame for getting it done. If you don't set a time frame and set a goal, they're going to take as much time as they want, and there's not going to be any initiative for them to push themselves to get things done more efficiently. Does that make sense to you?
Well, we do not have specified timeframes. You are correct. I would refer back to a comment that Mr. Joy made that all of our staff are incredibly dedicated, and we are all committed to
I'm not questioning their dedication. I'm questioning their efficiency and their time frames, and they don't have them. And to me, that causes concern, not just with myself, but with other members of this committee and people back home. I mean, you're telling me there's no window for when things will get done. Is that correct?
We do not have time frame targets. That is correct.
Do you have a plan to fix that, or are you just going to keep doing estimates?
As I stated before, our plan is to monitor our metric. We've got 2 quarters now, only 2 quarters worth of data on how long it takes us. We are looking at when we get additional staff, what impact that makes, so that we can make an assessment of what.
You don't have the ability to pull up prior cases going years back to see what time frame those took?
We could. Our current metrics show time frames to complete going back to fiscal year 11-12.
So there's plenty of data right there. I mean, you have the tools in front of you, ma'am, to develop a time frame. There was a time frame in place. I don't see why we're spending time going forward where there is not a time frame in place to get these things done and take care of people. It makes absolutely no sense. That's all I got.
Mr. Gibson.